Let's have a look at entire orthopedics in 100 lines. Let's go. Orthopedics means straight child. Nicolas Sendre gave this word, called as the father of orthopedics. The second father is Thomas, who gave Thomas splint and Thomas test for hip flexion deformities. Charles is called as the father of arthroplasty. When you look at X-rays, it can show you the bone, it can show you the soft tissue planes, it can show you the cortex in the bone, it can show you the marrow. What it cannot show you is the cartilage. When you look at the CT scan, it can show you the calcifications, it can show you the cortex. CT scan, C. Cortex, C. Calcification, C. But it's rarely an investigation. In orthopedics, if you want to choose an investigation, go for MRI because it can show you the marrow, it can show you the soft tissue, it can show you the cartilage. Cartilage is not seen on X-rays, is not picked up on CT scan, it's picked up on MRI. When I look at tumors and infection, which are usually the scenarios given to you for diagnosis, biopsy or tissue is the gold standard. Radiology is suggestive. Tissue is diagnostic. When I look at metastasis, PET scan is the investigation, the radiological investigation of choice, but bone scan is preferred in osteoblastic mets. And can you guess what causes osteoblastic mets? Prostate. So prostate is known for causing osteoblastic metastasis. Periosteal reaction came in NEET PG 2024, paper 1, paper 2. When they show you any periosteal reaction which is single layer solid periosteal reaction is benign bone tumor or acute osteomyelitis. When wide zone of activity, 3-1, they ask you, number 1, sun ray appearance, usually osteosarcoma. Codman's triangle, usually osteosarcoma. Onion peel appearance, usually Ewing sarcoma, but the location of the tumor is more important than these radiological images. So think about Ewings in the middle of a bone, diaphysis, and osteosarcomas on the lower end or the upper end, the metaphysis. Remember, in osteomyelitis, you will get an X-ray done first, followed by MRI. But MRI shows you changes within 6 to 12 hours, whereas X-rays will show you loss of soft tissue plane after 24 hours and periosteal reactions on day 7 to day 10. When we look at the infections, the king of orthopedics is Staphylococcus aureus. Osteomyelitis comes through blood, hematogenous, is in the metaphysis. And when they ask you the organism, remember that Staph aureus is the king. The exception that you should remember is sickle cell anemia, salmonella, and foot is something where you should think about. An IV drug abuser, you should think about Pseudomonas. Osteomyelitis, when it's chronic, which is one of the most common the images shown to you in orthopedics, think about sequestrum, the dead bone, which is diagnostic. And when you remove the sequestrum, the live bleeding bone comes. That's called as the paprika sign. Remember, multifocal osteomyelitis, that is osteomyelitis involving the multiple bones, right? Sapho syndrome is number 1. Sapho syndrome is a misnomer. It is actually an osteitis. But if they ask you which is multifocal osteomyelitis, choose Sapho syndrome. Second common is sickle cell anemia with salmonella infections. Faber, flexion, abduction, externodation of the lower limb is a position of increased capacity of the hip joint, which is seen in synovitis, infection, anterior dislocation, and when there is iliotibial band contractures. Faber is usually associated with lengthening. Opposite of it, flexion, adduction, internotation, that is FADER, is indicative of arthritis or posterior dislocation. So posterior dislocation more common than arthritis. Trauma, posterior dislocations are much more common than anterior dislocation. That is why Faber, anterior dislocation is a cause later. But in FADER, posterior dislocation is number 1 cause. And remember, FADER, shortening is there. Faber, lengthening is there. If you look at the infections of the joints, they are surgical emergencies called as septic arthritis. Organism is Staph aureus. Less than 5 years, toxic child. Compared to it, transient synovitis, temporary proliferation of synovium, age group is 6 to 12 years, non-operative management. Infections of the hand. The most common infection of the hand is the infection of the nail bed called as Paronychia organism Staph aureus. Infections in the phelon or whitlow is the infection of pulse space of finger. The organism, again, the king of orthopedic, Staph aureus. When you look at a chronic disease we live in India, we talk about tuberculosis. Tuberculosis of bone and joint is usually secondary, comes from the lungs or the lymph nodes. Tuberculosis of bone and joint is just like Shah Rukh Khan, SRK, SHK, spine, then hip, the knee. TB spine, also called as pot spine or cock spine, will never involve a single vertebra. It will involve two contiguous vertebrae with the intervening disc called as paradiscal involvement. The disease is anterior to the neural tissue, that is the spinal cord, as you can see in this image, and the disease rarely involves the posterior elements, that is, the involvement of the facet joints or the spinous process is rarest in TB spine. Remember, tuberculosis spine is treated by middle path regimen. What means is anti-tubercular therapy, where rifampicin is the most important drug, plus rest to that body part and surgery when indicated. What does that mean? It means that you will operate only when required. Not that you will never operate, not that you will always operate. Remember, in TB spine, right, because of the paraspinal muscle spasm, the loss of curvature of the spine is seen much earlier than the reduced disc space. But the tuberculosis of other parts of the body, where the blood supply becomes more because infections get inflammation, inflammation gets more blood supply, there is osteopenia around the joint called as peri-articular osteopenia. Remember this, when we look at tuberculosis of the knee joint, right, there can be a triple deformity, which is posterior subluxation, externodation, and flexion, whereas TB hip has got 5 stages. Stage 1, remember Faber-Fader? Faber, synovitis, lengthening, good prognosis. Stage 2 and 3 are stages of arthritis. There is flexion, adduction, introduction in stage 2, less than 1 centimeter shortening, which is not clinically appreciable. Stage 3, late or advanced arthritis. Whenever they mention shortening, it's automatic. They're talking about more than an inch. Forget about more than a centimeter. So mark stage 3. Stage 4, the acetabulum is destroyed. The femoral head is destroyed. The destroyed femoral head migrates from one corner acetabulum to the other, called as wandering acetabulum. It should be better called as wandering femoral head, but it's a misnomer. And finally, stage 5 is fusion of the joint by fibrous tissue called as fibrous ankylosis. Friends, arthrodesis is surgical fusion of a joint. The surgeon fuses. Ankylosis is pathological fusion of a joint. The disease fuses. The disease will not know how much to fuse. If it fuses completely, is bony ankylosis, painless. If it fuses incomplete, fibrous. Fibrous as F, painful ankylosis. TB spine, bony ankylosis. Everywhere else, tuberculosis will cause fiber ankylosis. Bony fusion, that is bony ankylosis, is solid. Solid is painless. S for solid, S for septic arthritis. So bony ankylosis, most common cause is septic arthritis. S for spine, S for solid. Spine TB, bony ankylosis. And again, one more S in a disease called as ankylosing spondylitis. Ankylosing spondylitis, young man, low backache, reduced sex expansion, decreased lumbar movements, heel pain, eye pain. HLA B27 positive. So this is how it goes. Fibrous fusion, right? In cases of fibrous fusion, you have R. So rheumatoid arthritis called as fibrous ankylosis. So these are important points about tuberculosis. Let's go to bone tumors, benign tumors, well-defined margins, uniform consistency, hard, firm, soft. Malignant tumor, ill-defined margins, variable consistency, somewhere hard, somewhere firm, somewhere soft. When you look at the lines that diagnose the bone tumors, remember, single central cavity, upper end of humerus is unicameral bone cyst. It will have fallen fragment or fallen leaf sign seen in upper end humerus. Again, coming to tibia, multiloculated, eccentric, hemorrhagic fluid inside it, aneurysmal bone cyst, metaphysis. Before skeletal maturity, both the cysts are seen. night pain, relieved on taking salicylates or aspirin, sometimes might disappear, is a lesion of the cortex seen in diaphysis. So, diaphysis, the moment it comes to you, remember there are three tumors, and all three they start with vowels: O, osteoid osteoma; E, Ewing sarcoma; A, adamantinoma. And out of them, remember, the tumor for which you will do a CT scan, majority of the investigations in orthopedics are MRI. The tumor for which you do the CT scan is the one, a cortical tumor, and that is osteoid osteoma. Pain relieved on taking salicylate, that is night pain. This nidus, or the growing center of osteoid osteoma, is the seed. It has a lysis surrounded by sclerosis. When you look at something which is large to feel, small on x-rays, it means when you touch it, you will feel the bone and you will feel the cartilage. But when you will click an x-ray, you will only see the bone because x-ray can't show you cartilage. This is osteochondroma growing away from the bone. And this osteochondroma, remember, if the hyaline cartilage covering over it seen on MRI more than 2 centimeter, it indicates a malignant transformation has occurred. Epiphyseal lesion at the upper end humerus, which is cartilaginous, is called as the Codman's tumor. It's not the periosteal reaction. It is Codman's tumor or chondroblastoma, again seen before skeletal maturity. Hand and feet. Most common tumors of bones of hand and feet are enchondromas. Most common tumor of hand is squamous cell carcinoma, but bones of hand and feet is enchondroma. The joint goes till the joint. Tumors, they respect the joint, they respect the cartilage, they will never eat it. The tumors, they respect the joint, they respect the cartilage. Infections eat both. The only tumor which can involve the joint and eat the cartilage is the giant. So the giant cell tumor goes till the joint. Remember that it is a tumor which seen after skeletal maturity. There is egg shell crackling on touch. It loves to eat the bone. There is soap bubble appearance. It is epiphysiometaphyseal. And Robbins' textbook of pathology says it can involve the cartilage, it can go inside. And the treatment is extended curettage. Curettage means jhadu lagana. Extended curettage is putting a chemical over it, means jhadu ke saath pocha lagana. The most common chemical used at our homes for pocha lagana is phenyl. We are orthopedic surgeons, we will use phenol, but the best is liquid nitrogen. Best means least chances of coming back, reoccurrence. Remember, bone tumors are more common in males. The two tumors which are more common in females are G for girls, G for GCT, F for females, F for fibrous dysplasia. And what exactly is fibrous dysplasia? It is bone replaced by fibrous tissue, leading on to Shepherd crook deformity at the upper end of femur, associated with a ground glass appearance of the bone, Rind sign at the upper end femur, and leading on to McAcune-Albright syndrome, which means pigmentation, that is coffee colored spots, precocious puberty, means early puberty, and polyostotic, means multiple bones fibrous dysplasia. It's very, very important. Now, if histiocytes proliferate and destroy the whole body, it's called as Langerhans cell histiocytosis. Langerhans cell histiocytosis, litter sway disease, fatal. If it destroys the eyes and the bones, right? This is called as Hand-Schüller-Christian disease. Involvement of endocrine system is also seen here, causing diabetes insipidus. But when it destroys only the bone or the lung, it is called as eosinophilic granuloma. Eosinophilic granuloma is a self-resolving condition. And remember, in medical science, whatever is self-resolving is always asked as a question. That's a rule. And eosinophilic granuloma on histopathology will have a cell with a coffee bean nucleus or a bilobe nucleus. That's how you pick it up, right? Then comes the malignant lesions. First decade or maybe second decade, middle of a bone is Ewing sarcoma. Second decade, end of a bone is usually osteosarcoma. The periosteal reactions can always be overlapping. Remember, 3 exceptions. Love triangles in tumors. First decade loves Ewing's, but Ewing's loves second decade. So Ewing sarcoma is more common than in the second decade, but first decade most common bone tumor is Ewing's. First love triangle. Second, lower end radius loves giant cell tumor. In fact, it's said that tumor of lower end radius is GCT, TPO, till proved otherwise. But giant cell tumor, most common location is lower end femur. Third, ameloblastoma loves mandible. But mandible, the most common tumor is squamous cell carcinoma. Right? So this is what we've just done. Second decade, metaphyseal, Codman's triangle or sundry appearances, osteosarcoma. Metastasis to the bone. They come from the breast, prostate, or lung, and the most common area is the thoracic spine or the dorsal spine. Punched out lytic lesion of the skull is characteristic of multiple myeloma. Beveled edges or the sloping edges of the skull is seen in eosinophilic granuloma. Large lytic lesion called as permeative lesion is seen in Langerhans cell histiocytosis. Salt pepper appearance is seen in hyperparathyroidism. All right. When you have trauma, remember the rule, you stabilize the cervical spine. ATLS guidelines say after that, airway, breathing, and circulation. When you look at nerve injuries, what recovers 100% is neuropraxia. It's a physiological damage. It comes back like a moment. The moment a love happens, that's the moment neuropraxia recovers, right? If there is damage to the axon sheath, recovery will occur proximal to distal, called as motor march. Tinel sign is positive and progressive. And when there is complete nerve transaction, it's called as neurotemesis. No recovery without surgery. Tinel sign, a sign of recovery, is positive but static. What is the positive rate of recovery of any tissue in human body? 1 mm per day. Remember, electromyography is the best test for nerve recovery, and nerve conduction velocities are carried out for compression neuropathy, out of which carpal tunnel syndrome for median nerve compression around the wrist is the commonest. Sensi supplies. The tip of index finger is supplied by the median nerve. The tip of little finger is supplied by the ulnar nerve. The dorsum of the first base is supplied by the radial nerve, the superficial branch of the radial nerve. Remember, the proximal humerus upper end, the regimental badge sign is there, right? That's the axillary nerve. Around the shaft of humerus, the radial nerve will get damaged, causing wrist drop. Behind the medial epicondyle, the ulnar nerve will get damaged, causing the ulnar claw hand, because there is paralysis of lumbricals, which make a L in your hand. Tuk. L in your hand, lumbricals. The lateral two are supplied by the median nerve. The ulnar two are supplied by the ulnar nerve. This is the action of lumbrical. Their paralysis causes claw hand. Hyperextension of metacarpophalangeal joint and flexion of the interphalangeal joint. And when you apply a splint to flex them, replicate the action of lumbrical, it's called as knuckle bender splint, because you're bending the metacarpophalangeal joint, the knuckles, called as a knuckle bender splint. Right around the head of radius, you have a complete motor branch of the radial nerve called as posterior introitious nerve, which will cause finger drop. Radial nerve, wrist drop and finger drop. Posterior introitious nerve, a pure branch, only the finger drop, right? And when you come to the lower limb, behind the hip, in posterior hip dislocation, the sciatic nerve is damaged. And in today's world, the most common question asked, around the neck of fibula, the common peroneal nerve is paralyzed, causing the foot drop, which is very, very important. Coming to the test for the nerve injuries, ulnar nerve and median nerve, their tests are important, because the test of radial nerve are not there, because there is no test for the radial nerve, because the radial nerve is the most commonly damaged nerve. It has the best prognosis, and anything which has the best prognosis is never tested, right? So the tests for the ulnar nerve are the CART test for palmar introitiae, the Igawa test for the dorsal introitiae, the Book test for adductor pollicis, the Froment sign, if it is paralyzed, called as FU, Froment sign ulnar nerve, and the Wartenberg sign, the abducted little finger for ulnar nerve. Whereas when we talk about median nerve, there's one test called as pointing index. You make a fist, these two fingers stand out, that's pointing index, also called as a benediction attitude, also called as a Ochsner class test. For other tests for median nerve, you have a pen test. If you give pen over the palm and you ask the patient to touch it, he will not be able to touch it. It means there is abductor pollicis brevis, which is paralyzed. The last test for the median nerve is the ape thumb deformity. The thumb is supposed to do opposition. If it comes in the same plane as palm, that is paralysis of the median nerve, loss of apposition, because ape thumb deformity. For radial nerve, there is no test. All right. So this is what you should see. These images are showing you ulnar or radial nerve palsy is causing claw hand. And if you're asked about the claw hand, mark ulnar nerve more than median nerve, knuckle bender splint, ulnar more than median, because ulnar nerve palsies are more common than the median nerve palsy. Coming to the compression neuropathies, I told you carpal tunnel syndrome around the wrist causing median nerve palsy is the commonest, more common in females. The Durkin's direct compression test is the most commonly done test. And then you have the Ulta Namaste, the Phalen's test, or the reverse Phalen's test for the same, right? Then the important one is lateral cranial nerve of thigh compression, Meralgia paresthetica. Superficial radial nerve compression, the Chiralgia paresthetica. Then you have piriformis syndrome compressing the sciatic nerve. Remember, in compression neuropathies, femoral nerve is not involved. And one of the commonest compression neuropathy is compression around the base of the neck, called the thoracic outlet syndrome, compressing T1 and C8 nerve roots. And then you have tests for it, the Adson test, the Wright's test, and the Roos test. And then you have something that came as a small GIF in one of the INI-CET exams, the Allen's test for the patency of the radial and the ulnar artery. Shoulder is the most common joint to dislocate. Reason is simple. Ratio of the head to glenoid is 4:1. Whenever shoulder or hip dislocates, in anterior dislocation, the head is down and the arm or thigh is out. So it's down and out. In posterior dislocations, the head is up and thigh or arm is in. So it's up and in. Shoulder dislocation, the tests done are Dugas test, the Callaway test, and Hamilton ruler test. Bryant's test is also one of them. Methods to reduce: Kocher's, the most common one; Hippocrates, not to be done; Stimson's, gravity assisted reduction. Posterior dislocation is the most common missed dislocation in the human body of the shoulder. Epilepsy and electric shock are predisposing factors. Radiologically, you will have electric bulb-like appearance of the head or the empty glenoid sign, and the head is up and in. Rotator cuff muscles are SITS, SIT-S, supraspinatus, infraspinatus teres minor, insert on greater tuberosity causing abduction, external and subscapularis goes on the lesser tuberosity causing interrotation and is called as the forgotten tendon of rotator cuff, and the test is lift-off test. Rotator cuff tears repaired in young. If cannot be repaired, tendon transfers to be combination. Clavicle is the most common bone to fracture in human body. It fractures at the middle 1/3, and you have figure of 8 bandage for it. The nerves you've already done. Shoulder is axillary. Shaft of humerus is radial, but at lower 1/3 level called as Holston-Lewis sign. Medial epicondyle, the ulnar, radial head, the posterior interosseous nerve, hip, the sciatic, knee, the common nerve causing foot drop or high stepping gait. Supracondylar humerus is an extra-articular fracture, is known to undergo malunion, causing the cubitus varus or the gunstock deformity. And the nerve involvement are anterior interosseous, median, radial, ulnar. Supracondylar humerus is classified by Gartland classification. Type 1, undisplaced fat patch sign. Type 2, posterior hinge. Type 3, displaced. Whether it's posteromedial, posterolateral, you don't need to know. And the image that came in last exam was type 3. Type 4 is complete tear of the hinges, intra-op, so not to be marked. Whereas lateral condyle humerus is an intra-articular fracture, undergoes non-union, causing cubitus valgus, causing slow onset tardy ulnar nerve palsy. Remember, extra-articular fractures, close reduced. So supracondylar humerus, close reduced plus K-wire fixation. Lateral condyle humerus, intra-articular fracture, open reduced. So open reduction plus K-wire fixation. If there's an injury to the joint, remember, both active means I will do it myself and you cannot move my joint. So active and passive movement restricted. But extra-articular fractures, the active movement, I can't do it, but you can move it. Passive are permitted. Elbow dislocation. The most common dislocation in human body is shoulder. Shoulder goes anteriorly. Most of the other goes posteriorly. So elbow dislocation is posterior, causing ulnar nerve damage, and this is the most common dislocation in a child. Shoulder is not the most common joint to dislocate in a child. Trauma. Remember this: CC, MM, SS, FF. C for compartment syndrome, C for cast. M for myositis, M for massage. S for sympathetic overactivity, S for Sudex dystrophy. F for femur fracture, 48 hours, F for fat embolism. Compartment syndrome, the earliest sign is stretch pain and microcirculation is affected. Myositis is always a history of massage, and you should not be doing any massage. Sympathetic activity, overactivity is a mark of Sudex. You will have red hot shiny skin and osteopenia. Femur fracture, fat embolism is seen after 48 hours. There will be breathlessness, confusion, and petechial rashes. Compartment syndromes are more common in lower limb fracture tibia, causing deep compressions. Myositis ossificans is usually seen around elbow, involving the brachialis more than biceps. Sudex is usually seen with extraarticular posterior displaced fracture of the radius called as Colles, and fat embolism, long bone fracture, usually femur fracture. Remember, compartment syndrome, myositis, Sudex, or fat embolism all have poor prognosis, but fat embolism has high mortality, poorest amongst them. When we look at Colles, Colles is something that examiners love, is an extra-articular fracture with posterior displacement. Priyanka Chopra, posterior Colles. And this leads on to the most common complication being finger stiffness. But in MCQ world, they ask you dinner, fork, deformity. This is what is occurring. Opposite of Colles is called a Smith. Occurs on fall on a flexed hand, causing garden spade deformity. It is Anushka Sharma. Anterior displacement is Smith. This is what you should remember. Both Colles and Smith are extra-articular. When we talk about intra-articular fractures around the lower end of radius, there are two of them. The radial styloid goes called as the Chopard's fracture, the Chauffer's fracture. Chauffeurs, because when they exert a sudden force, there's a pull of a muscle causing separation of the radial styloid. It's an intra-articular fracture. And the second one, if there is a damage to the joint with wrist movement, this is called as a Barton fracture. If it goes entirely, volar Barton. If it goes posteriorly, dorsal Barton. When you come to the base of first metacarpal, we have two intra-articular fractures. Mind you, intra-articular fractures in the books confuse you for that. The first one is fracture with a dislocation called as Bennett's fracture dislocation. Second one is comminuted fracture of base of first metacarpal called as Rolando. Both are intra-articular. That is what you should remember. Coming to combination of fractures with joint displacement, fracture of ulna with dislocation of the radial head is Montagia. The more common variety of this combination of forearm is fracture of radius with damage to the distal and radial ulnar joint called as Galeazzi. Galeazzi is more common, so it's more commonly asked in entrance exams. When I look at the damage to the spine, there are three scenarios. Number one, spine has got damaged. You have no sensation, no motor power beneath that level, called as spinal shock. It can recover within few hours to few weeks. This spinal shock, the first sign of recovery is return of bulbocavernosus reflex. The terminal end of spine called as conus medullaris, if that's damaged, there will be asymmetrical loss beneath it with bowel bladder involvement. Or if the horse's tail, the nerve roots at the end of the spinal cord is damaged called as cauda equina syndrome, it will be asymmetric loss with areflexia and bowel bladder involvement. Some of the important fracture of the spine, Jart. Jefferson's is a fracture of atlas, burst fracture of atlas. Hangman's H2, C2 over C3 slip is fracture involving the C2. C1 and C2 injuries usually have less neurological deficit. Also remember, young female bilateral hand pain with morning stiffness is RA. And this is what you can do. Usually take your hands up. And that is why RA usually involve the upper cervical spine or the base of skull. Remember, this question came in this INI-CET this year. If you are going in a vehicle, there's a sudden halt, your neck goes back and comes forward. This is called as whiplash injury, hyperextension followed by flexion. And then if you have got an injury which separates your base of skull into anterior posterior, that's called as motorcycle or the hinge fracture. If it's a child less than 8 years of age and he has a spinal cord injury and you cannot see it on the x-rays but see on MRI, this is called as Skyvora, spinal cord injury without obvious logical abnormality seen in less than 8 years of child. If you look at the curvature of the spine, cervical spine goes in, called as cervical lordosis. Thoracic comes out, called as thoracic kyphosis. Lumbar spine goes in, called as lumbar lordosis. The question that comes to is, what is the normal curvature of lumbar spine? Lumbar lordosis. The lateral curvature of spine is called as scoliosis. And the angles which measure scoliosis are called as Cobb's angle and used for its treatment. And one more sign here is Reiser's sign used for the treatment of scoliosis. Scoliosis, if it is postural, you bend forward, it disappears. called as Adams forward flexion test. Scoliosis, if there is normal vertebra, it means it's a idiopathic scoliosis. And if the development of the vertebra is hampered, called as congenital scoliosis, all three come as an image. Around the hip, there are two tests. One is for hip stability, which is dependent upon a normal hip, the gluteus medius and minimus and their nerve supply called as superior gluteal nerve. If you stand on one limb, opposite side drops, it means that side gluteal nerve or gluteus medius minimus or the joint is gone, called as Trendelenburg test positive. Positive means drop on the opposite side. And then hip flexion deformity, you have a test by the second father of orthopedics called as H.O. Thomas. That's for hip flexion deformities. You can be asked to identify intertrochanteric fractures between the two trochanters, the greater and the lesser trochanter. What inserts from greater trochanter? The gluteus. What comes on lesser trochanter is iliopsoas. MCQs. Intertrochanteric fractures, also called as extracapsular fractures, they have extra age, usually around 80, extra shortening, extra external rotation, extra pain, extra everything extra, but unites, malunion. Coxa vara, reduced neck shaft angle of femur. Intracapsular, also called as neck of femur, right? Less than 60. Both the fractures are more common in females. Less external rotation, less than 45 degrees, less shortening. Shortening and external rotation are the features of neck of femur fracture. Also, neck of femur fracture is also called as on day one the unsolved fracture. Neck of femur fractures are the fractures which are dependent upon the age to treat. If the patient is less than 60, you are going to treat the patient, in fact, less than 65. You're going to treat the patient with closed action plus screw fixation. 65 or more, you will replace the head and neck called as hemiarthroplasty. Any age, if the joint is damaged, you will do arthro, total hip replacement, that is total hip arthroplasty. Whereas extracapsular fractures, from the tip of trochanter to the base of the femur, usually nailing is done. Closed action plus intramedullary nailing is done. When we talk about hip dislocations, posterior dislocation causing farther plus shortening is more common than anterior dislocation where there is Faber plus lengthening. Posterior dislocations, the nerve palsies are more common. Anterior dislocations, the damage to the arteries can occur, and long-term complications of any dislocation is osteoarthritis of that joint. Some named fractures going from the top to the bottom. We did the spinal injuries. Tibial pylon fracture is intra-articular fracture, lower in tibia, very commonly asked. The talar fractures, the aviator fractures can cause osteoarthritis. More of the subtalar joint, that is talocalcaneal, than the ankle joint, more common than avascular necrosis. And then you have the lover's fracture called as the calcaneus fracture, occurs due to vertical height fall. And there are two angles measured here, Bohler's, which lowers in fracture calcaneum, Gizane, which gains in fractures of calcaneum. Some more angles in orthopedics. We also have angles. Cobb's angle we spoke about is for scoliosis. Bauman's angle for supracondylar humerus cubitus varus. And then you have Kite's angle, the king of CTV, the clubfoot angle. If you are trying to treat fractures with splints, you have hanging cast for fractured humerus. You have U-slab also fractured humerus. You have cylinder cast or tube cast for the knee joint. You have patellar tendon bearing cast for tibia. You have the hand shaking cast for the commonest asked fracture to you guys, the Colles fracture. You have a glass holding cast for the scaphoid, anatomical snuff box tenderness scaphoid. Patient comes to you, immediately you don't see anything, you follow a rule, apply a thumb spica or a glass holding cast, ask him to come back after 2 weeks with a new x-ray. And this fracture is known for non-union, more common than avascular necrosis, whereas neck of femur has avascular necrosis more common than non-union. So scaphoid fractures at the waist, and the blood supply comes from the distal to proximal called as retrograde blood supply. That is why the proximal pole undergoes avascular necrosis. When we look at the fracture shaft of femur, from the first 5 years of life, treatment is spica. If you apply a slab, plaster of Paris on a surface, it's a slab. S for slab, S for surface. When the plaster of Paris goes around, it's a cast. C for cast, C for circumference. When this cast goes around the spine, it's called as a spica. A cast that goes around the spine, right? Less than 5 years of age, you give a spica for fracture shaft femur. In older times, gallows traction was give given for age group less than 2 years of age, but that's not the preferred treatment. You won't hang somebody's kid by the roof. Age group 5 to 10 years, fracture shaft femur, titanium elastic nail system, elastic thin nails. Beyond 10 years, you will lock it, called as interlocking nails, right? Some more splints that you should remember apart from gallows traction. The most common splint asked wrist drop, radial nerve palsy, cocker splint for it, and then claw hand, knuckle bender splint, ulnar more than the median nerve. When you look at figure of 8 bandage for clavicle, never been asked, can come to you. Dunlop or Smith traction for supracondylar humerus. Imagine Smith traction is not for Smith fracture. So Dunlop traction is going for a skin traction for supracondylar humerus, where Smith traction is a pin traction for supracondylar humerus. Both were used earlier. The treatment today is closed action plus K-wire fixation. Congenital telepathic equinovarus, also called as a club foot because it resembles the club, the golf stick used to play, the stick used to play golf called as a club. Dennis Brown splint, also called as the abduction orthosis, foot abduction orthosis, or Agnes Hunt, which is used for the hip flexion deformity, which is loved by the examiner, either Thomas test or the Agnes Hunt traction. Russell's, the classically described intertrochanteric traction, which is a skin traction, right, is also shown as an image to you, or a Pavlik harness for developmental dysplasia of hip, which is because of the shallow acetabulum. When I look at the braces for scoliosis, Milwaukee brace goes till the chin for scoliosis, and Boston brace, the upper end of the breast or the axilla, again for scoliosis. When I look at the further braces, Ash brace used in osteoporosis, a plus shape brace, or a talar spinal brace going till the shoulder for the traumas of the thoracolumbar area. When I look at the femur, the uppermost point which is palpable to you is the trochanter. If something happens to the head or neck of the femur, there is no way you can measure it. So there is a triangle to measure that shortening called as the Bryant's triangle for supratrochanteric shortening. And then comes a condition where between the two vertebrae there's an intervertebral disc is prolapse, is called as prolapsed intervertebral disc, and it causes back pain going down the limb, also called as a sciatica. Like everything in orthopedics, MRI is investigation of choice. Most common level is L4, L5, and that is why the most common nerve root compressed is L5 because the lower nerve roots are compressed. All the compression neuropathy like the disc prolapse, carpal syndrome, thoracic outlet syndrome, piriformis syndrome, Meralgia paresthetica, treatment is same. Plan A. It's a name we have given. Rest plus NSAIDs. If not relieved, local steroids. If not released, surgical decompression. When I look at the important nerve roots to remember to mark it, L4 is for ankle dorsiflexion and supplies the middle part of the foot. L5, the most common nerve root compressed in the human body, causes the extension of the great toe and supplies the lateral aspect of the foot and the great toe all around. And S1 supplies the sole and the little toe and flexor hallucis longus and also the ankle reflex. Slip of one vertebra over the other, called as spondylolisthesis, occurs because of one of the predisposing factor called as spondylolysis. Spondylo means vertebra, lysis means break. Vertebra breaks where? At an area called as pars interarticularis. That is called as a neck of the dog because you see a dog on the oblique or lateral view of spine. So spondylolysis most commonly occurs at L5 vertebra called as dog with a collar in the neck. Whereas when the neck breaks, the head falls, called as spondylolisthesis, which is beheaded Scottish Terrier sign occurring at L5 S1 level. So in the order I taught you, you can remember L4, L5, disc prolapse. I taught you first. Spondylolysis, L5 level, right? Dog with a collar in the neck. L5 S1 spondylolisthesis beheaded Scottish Terrier sign. When I go further, it is very, very important to remember the joint disorders, osteoarthritis. Osteoarthritis, if you say something like this, OA, to somebody, the two joints that points towards him are involved in OA. That is DIP and PIP. What is paired is MCP. Again, in osteoarthritis, base of thumb, the first carpometacarpal joint, and also the knee is commonly involved. But DIP is the king here. When you look at rheumatoid arthritis, you say RA, RA, RA. So MCP and PIP are involved, DIP is paired. When you look at osteoarthritis of knee, right, the medial compartment is involved. It causes genu varum. Varum means distal part towards the midline. If this is my elbow, and from the elbow, the distal part goes towards the midline, it's cubitus varus. Beneath the knee, genu varum. So osteoarthritis causes genu varum. Medial compartment involved. Important thing to remember. Quadriceps is the most commonly wasted muscle. Less than 60 years, if the patient has disability, activity of daily living are affected, the first thing you will do is correct the deformity called as high tibial osteotomy. Every varus, you take out more bone from the lateral side called as lateral wedge osteotomy. If the age is 60 or more, you will replace the joint, total knee replacement. Fantastic results. All right. And if you look at rheumatoid arthritis, RA, right? Young female, bilateral hand pain, morning stiffness, MCP commonly involved, DIP spared, right? Is rheumatoid arthritis. RA will cause genu valgum in the knee. OA, you can make an O between the legs, whereas RA, it's like a R between the legs. Swan neck and boutonniere deformity, they will always show you the side views. The ulnar deviation of the finger in RA. Whereas the swellings of DIP and PIP in osteoarthritis called as Bouchard's nodes at the PIP or Hubbard nodes at DIP, front view will be seen. So OA, they will show you the front view. RA, they will show you the side view. Ankylosing spondylitis. Young male, low backache, reduced sex expansion, red eye, heel pain, HLA B27 positive, white skeleton, fused skeleton, bamboo spine, an inverted knife in the center called as dagger sign. Inverted knife in the center with ossification of facet joint on the side, trolley track sign. Shining corner called the Roman sign. What is more important here is the diagnostic feature in ankylosing spondylitis is radiographic sacroiliitis. Most of the conditions in orthopedics are painful. The most common symptom of ortho is pain. Two conditions which are painless. One is mycetoma, which is subcutaneous infection of the foot and the sole, causing multiple discharging sinuses with the colonies coming up with a painless swelling. If it is due to fungal cause, it is called as Madura foot. If it occurs at the angle of jaw, it's called as actinomycosis. The second painless condition in orthopedics, which occurs in diabetic patients, is called as loss of proprioceptive fibers, neuropathic joints, Charcot's joints. In Charcot joints, the anatomy is deranged, the joint is destroyed, looks bad, feels good. This is the only condition in orthopedics where you can fuse a joint because life is movement, movement is life. If joint is damaged, you replace it. But in Charcot's, because the proprioceptive fibers are gone, it is safer to fuse it. Nowadays, people do replace, but the indication for you as a student is going to be fusion. Inflamed great toe. Middle-aged businessman, they drink and eat every day. Combination of protein alcohol intake is gout. You have uric acid crystal deposition in the joints that proves it. How will you prove it? You throw a light with a polarizing microscope. If the light goes left, it is negatively birefringent. If it goes right, it is positively birefringent. In gout, it's negatively birefringent. Right? Inflamed great toe. There are rat bite erosions around the joint. Overhanging bony edges called as a martel sinus gout. Whereas pseudogout is a calcium pyrophosphate deposition, calcification of the cartilage and meniscus, which is called as chondrocalcinosis, rhomboid shaped crystals, and positive birefringence. Gout, uric acid crystals, needle shaped, negative birefringence, pseudogout, positive birefringence, rhomboid shaped crystals, and they are going to be causing chondrocalcinosis. When I look at widening of a joint due to defect in the calcium phosphate or vitamin D metabolism with normal to low calcium, low phosphate, high parathyroid hormone, high alkaline phosphatase. I'm talking about rickets, cup shaped metaphysis, widened, splaying, and flaring, they point out. You give calcium vitamin D to the patient, you will see a white line called as white line of Frankel. White line of Frankel indicates healing rickets. In rickets, the phosphate is usually low. Can you name a rickets where phosphate is high? You're right. It's chronic renal failure rickets. Remember in rickets, the parathyroid hormone is always high. Can you name a rickets in which PTH is normal? Yes, hypophosphatemic rickets, where the deformities are more obscure. So rickets can have genu can have genu but in hypophosphatemic rickets, in one leg you can have varum, the other can have valgum. What is that called as? मैं ऐसा क्यों हूं, मैं ऐसा क्यों हूं of Hrithik Roshan, called as wind swept deformity. Whereas rickets is widening, so scurvy is whitening. The bony edges, they look white. In rickets, the epiphysis is normal. In scurvy, there is sclerotic margin of epiphysis called as Wimberger ring sign. Remember, in rickets, the white line of Frankel is only in healing rickets, whereas scurvy, white line of Frankel is always, always present. So this is what you should remember. Hyperparathyroidism, PTH, acts on osteoblast, releases the rank ligand. Rank ligand attaches on osteoclast, and this causes osteoclastic resorption when there is too much of PTH and PTH adenoma. When there is abdominal groan, when there is psychic moan, when there is renal stones, there will be bones. And there will be lytic cavity in the bone because there is resorption called as cystica, filled with fibrous tissue, fibrosa cystica. In the bone, osteitis, fibrosa cystica, when there's blood inside it, and you do a histopath, you open it, it will be brown in color called as brown tumor. So these brown tumors are not tumors, they are seen in hyperparathyroidism. And in this condition, you have dot on the skull, called a salt pepper skull. In this condition, the bones can look like the fence post, white in color, called as the rotting fence post appearance. Remember that when you have chronic renal failure, CRF, you have high phosphate. And in this condition, the PTH also goes out. That is a secondary hyperparathyroidism. And here they have a condition called as rugger jersey spine. Rugger jersey, rugby players have alternate bands. Classical of CRF can also be seen in a condition called as osteopetrosis. What is osteopetrosis? It's an osteoclast defect where you have bone within a bone appearance, no marrow cavity. There is delayed healing. Most of the generalized disorders have normal fracture healing, but osteopetrosis can have delayed healing. It can cause compression of the cranial nerves. And osteopetrosis is a condition, right, which is very commonly asked you as an image, but the skeletal shape is maintained. Paget's, if you look at another osteoclast defect, multifactorial cause, but osteoclast defect, it is known to occur beyond 50 years of age, more common in males. High alkaline phosphatase, high resorption markers. And Paget's is a disease which is pain the commonest symptom, pelvis is the commonest bone affected. And if you look at Paget's, there are so many neurological features which are seen in Paget's: cotton wool skull, right? Osteoporosis circumscripta. In Paget's, you can have a thickened pelvic brim called as a brim sign. You can have white vertebra called as ivory vertebra. You can have a boundary of a vertebra which looks more white called as picture frame vertebra. Pages is something which can have resorption of the long bones, right, which is called a blade of grass appearance. Pages images are very commonly asked. Where osteopetrosis, usually we have rugged jersey spine, but rugged jersey spine is classically seen in chronic renal failure. When the bone quality drops, when the bone quality drops, its rickets, adult counterpart is osteomalacia. When the bone quantity drops without drop in the quality, that's called as osteoporosis. In osteoporosis, calcium phosphate, alkaline phosphate is normal. It is measured by DEXA scan, dual emission X-ray absorptiometry. We calculate T score, compare it with a 30-year-old individual. T score, we are going in negative, 0 to -1 normal. -1 to -2.5 is osteopenia. Below that is osteoporosis, less than -2.5. Osteoporosis with a fracture is severe osteoporosis. The order of fractures is vertebra, then the hip, then the colis. In osteoporosis, the investigation of choice is DEXA. In osteoporosis, bone resorption is more. That is why tartrate resistant acid phosphatase can be high. In osteoporosis, you have something called the FRAC score, which is a fragility score to find out the fragility of the bone, the fractures of the bone. In Paget's, I told you, is osteoclast defect involves the pelvis. Most common symptom is pain, ivory vertebra, cotton wool skull. Osteopetrosis, rugged spine, marble bone disease. Osteogenesis imperfecta. Bone has word 1, type 1 collagen. When it's defective, multiple fractures in childhood called as osteogenesis imperfecta. All right. If your hand is crushed and you want to know the survival, You will calculate something called as a MES score, which has 4 components: shock, that is the blood pressure; ischemia, distal circulation; velocity of trauma, whether it's a fall from 2 feet or 100 feet; or age of the patient. Younger the age, the better the healing power. MES score tells about survival of a limb. Total score is 11. More than equal to 7 indicates it won't survive amputation. When we talk about an amputated limb and you want to put it back, the first structure to be fixed is bone, followed by, if it's upper limb, extensor tendon, flexor tendon, you're coming from down to up, artery, nerve, vein, and the skin. Skin is preserved first, repaired last. If somebody comes to you with an amputation, they could show you an image of above knee amputation, below knee amputation, above elbow, below elbow amputation, amputation above the ankle, Syme's amputation, amputation to the intertarsal area called as Chopard's amputation, amputation to the tarsometatarsal area called as Lisfranc's amputation. And when you want to replace the foot with a prosthesis, you have a natural looking barefoot walking foot, which can allow you to sit on the ground, a Jaipur foot. Or you can have a solid ankle cushion heel Western foot, which does not allow to walk barefoot. You cannot walk on uneven ground. You cannot squat. The Jaipur foot was designed by Dr. P.K. Sethi, a scientist of great eminence from Jaipur. When we look at the knee joint, you have two collaterals, the medial collateral and the lateral collateral. The medial collateral, which is more commonly damaged, is tested by the valgus stress test, and the lateral collateral ligament, which is less commonly damaged, is tested by the varus stress test. We have the two cushions of the shock absorbers, the medial meniscus, which is fixed to the underlying capsule, the lateral meniscus, which is mobile. लाइफ का रूल है, जो फिक्स होगा वो टूटेगा, जो रिजिड होगा वो टूटेगा. Medial meniscus damage more than the lateral meniscus. There are different type of tears. It can be bucket handle, it can be riddle tears. Medial meniscus or the lateral meniscus, blood supply comes from outside in. That's why the peripheral 1/3 is called the red zone. You repair the inner 2/3, you excite. Menisci are damaged with rotational force on a flexed knee. Knee can only be damaged when the knee is flexed and there's a rotation. But along with the flexion and rotation, if there's a valgus force, you will undergo a damage to the anterior cruciate ligament. ACL has got two fibers, anteromedial and posterolateral. The posterolateral fibers of ACL, they are more active in extension of the knee. When you test for ACL, you're looking to what? The function of it. ACL prevents the anterior translation of tibia on the femur, hyperextension, and is damaged in the same mode. The tested way is you pull tibia ahead, called the latchment test, done in 20-degree flexion, or the anterior draw test, done in 90-degree flexion. Latchment test, LAC, first three alphabets, ACL is the better test. The other tests are pivot shift or strange name Lely test. The PCL prevents the external rotation of the leg on the thigh, and the test for it is dial test, which also tests the posterolateral corner. Like the pivot shift test, it is testing for the anterolateral corner. Most common tendon to get damage in the human body is supraspinatus, followed by biceps, followed by tendoachilles. Remember biceps tear, the long head of biceps called as the Popeye. Sometimes this image comes to you. Most common ligament injured in human body is anterior talofibular ligament on the lateral side of ankle. One more ligament sometimes they ask you on the medial side of ankle is deltoid. If you try to catch a ball and your thumb goes into abduction, the ulnar collateral ligament of the first MCP can be damaged, called as the gamekeeper's thumb. The avulsion of extensor tendon from distal phalanx, called as the mallet finger, usually treated with a splint for 6 to 8 weeks. It's opposite. Avulsion of flexor tendon from distal phalanx, called as FDP avulsion, is called as a jersey finger. And jersey finger, the treatment is surgical fixation because the flexor zones are 5. 5 is forearm, 4 is carpal tunnel, 3 is a zone where the lumbricals are zone. Zone 2 is the zone for FDS. It is no man's land. You cannot operate here. And zone 1 is a zone for FDP, the jersey finger. Also at upper end of tibia, they will ask you the structures from anterior to posterior. Medical College Lucknow, Lucknow Medical College is a mnemonic, right? So what you need to remember is the most posterior structure at the upper end of tibia is PCL. And that is why when there is a posterior force on the tibia, PCL is damaged. And when there is a posterior force on the lower limb, posterior dislocation is there. So posterior dislocation followed by PCL injuries are the two causes which are involved in a dashboard injury. Remember that. Diabetic mellitus. One disease we did was Charcot's. The second one, adhesive capsulitis. The capsule fuses. All the movements are lost gradually, and treatment is plan A, as discussed earlier, for compression neuropathies. If your supraspinatus or your rotator cuff muscles are inflamed, subacute inflammation, the first 60-degree movement is normal. 60 to 120 degrees is painful. Beyond 120 is normal. This is called as painful arc syndrome. Treatment is plan A. Overuse syndromes, inflammation of the lateral epicondyle causing common extensor origin tendinitis, tennis elbow. Medial epicondylitis, golfer's elbow. Student's elbow is olecranon bursitis. Prepatellar bursitis is housemaid's knee. Infrapatellar bursitis is clergyman's knee. Sometimes they show you an MRI where the prepatellar area is inflamed. It came in January in FMGE exam in 2025, called as the housemaid's knee. All these conditions are plan A, and Cosine test is done for tennis elbow. Remember that. Lateral deviation of grade 2 as shown here is hallux valgus. Prominent calcaneal tuberosity is called as a Hangland deformity. Right? The blood supply of the head of femur is supplied by the medial circumflex femoral artery, and whenever it's compromised, it's called as avascular necrosis. AVN occurs at the following site. Number one is the head of femur, then the proximal pole of scaphoid, the proximal pole of lunate, the body of talus, the head of humerus, the distal femoral condyle, and the capitulum. The avascular necrosis is a dead bone. Dead bone is white and dead bone is light. Avascular necrosis, usually a history of steroid intake will be given to you. Avascular necrosis of the head of femur usually involve the anterolateral aspect of the head. Clinically, there is something called as a sectoral sign. On X-ray, Chanda Mama dikhta hai, called as a crescent sign. An MRI, which is the investigation of choice, will have a double line sign. In early stages, you decompress, called as co-decompression. Intermediate stages, take a muscle with its blood supply, muscle pedicle graft. Late stages, the most commonly done procedure overall, you replace the joint, called as total hip replacement. When we come to pediatric orthopedics, we look at the age to diagnose the patient. At birth, you have developmental dysplasia of hip, DDH. There is shallow acetabulum. Whenever there is shallow acetabulum, the head can dislocate out. It will usually go up and lateral. The Shenton's arch at the upper end of femur and the pubic rama is broken. You cannot feel the femoral artery pulsation, called as vascular sign of Narad, being positive. In DDH, remember one basic thing. The investigation of choice is MRI, but ultrasonography can be done, and alpha angle decreases in DDH. Any hip pathology, abduction interrogation is limited, and for DDH you have two tests. Ortolani, hip ko andar lana, bahar lo, dislocate karna. Ortolani and Barlow's test, and treatment is maintain the hip reduced. Von Rosen splint, bacillus cast, they are all used for DDH. They are and the Pavlik harness, they're very, very important. Age group for DDH is usually at birth, more common in females. Another disease which occurs in 4 to 8 years, avascular necrosis of the femoral epiphysis, called as Perthes disease, usually painless. Self-resolving, can have some important clinical features or the radiological features. They can be a crescent sign on the X-ray because loss of blood supply of the head. We saw it in the adult AVN. There can be a sagging rope sign at the upper end of femur, or there can be lysis of the epiphysis and metaphysis, called as Gage's sign. Perthes disease, again, you maintain abduction, can be reduced. Investigation of choice is MRI. The third disease occurs in overweight, hypothyroid males, 11 to 20 years of age. Again, decreased abduction and rotation. The metaphysis moves. The epiphysis stays at its place. The metaphysis moves. It's a misnomer, called a slipped capital femoral epiphysis, although the epiphysis does not move. Limitation of abduction and rotation. When you draw a line over the upper end of femur, the metaphysis, it should cut a part of epiphysis, called as Klein's line. When the line goes above the epiphysis, called as Strithoven sign. Treatment, fix in situ usually, if not osteotomies. When you look at the foot deformities, congenital talipes equinovarus or CTEV, also called as the club foot, there are four components: increased plantar arch called as cavus, medial division of forefoot and midfoot called as adduction, medial division of the subtalar joint called as varus, and plantar flexion called as equinus. CAVE, cave, this is the order in which you should correct the deformities. If not, there will be opposite of CTV called as rocker bottom foot. CTV is classified by Pirani scoring. The treatment is very simple. At birth, manipulation and cast goes up to 1 year of life. Any age you present, the first thing is this only to make it supple. 1 to 3 years, tight medial structures, release them. Majority of the deformities of our body are varus. So beyond 3 years, release the soft tissues, take a wedge. More on the lateral side, less on the medial side. And beyond 10 years, you fuse three joints, TNTCCC, talonavicular, talocalcaneal, calcaneocuboid. So these are the points about orthopedics in quick. Let's have single liners of MCQs. When we look at the Codman's triangle and sunburst appearance, the most common tumor that you should think about is osteosarcoma. When you think about WHO, how will you diagnose TB spine? It is going to be by biopsy because tissue is diagnostic. And what will you do in that? CBNAT. That is what the investigation to be done. When you talk about any fracture in intertrochanteric or the shaft of femur, how will you treat it? I will treat it with intramedullary nailing. When you talk about if there's a fouche in a patient and patient comes to you with anatomical tenderness, X-ray is normal, what will you do? I'll apply a thumb spica cast and ask him to come back after 2 weeks. When you talk about an RA patient with neck pain, what are you suspecting? Atlantoaxial instabilities, the upper end of cervical spine unstable. When you look at a child or an adult of 18 years of age, remember that the age of ossification, that is the skeletal maturity, is 18, 16, 18, 16, 18, 16. So at the age of 18, you usually are going to do a knee and a wrist X-ray. When you look at the longitudinal growth of a patient, if the epiphyseal plate of the physis is damaged, it is going to be affected. Area for which, if you have a diaphyseal area shown right in the middle of a femur and there is a presentation of an osteomyelitis, you must think about Ewing sarcoma because that is what is number one asked when the presentation of osteomyelitis is there. When the metaphysis is there and they show you an aggressive periosteal action, think about osteosarcoma. My friends, Ewing sarcoma has translocation 11 to 22. Remember that it's very, very important for you guys to remember. And remember an OK sign. This is for anterior trochlear nerve, a branch of the median nerve. And this is dependent upon the flexor pollicis longus and FDP lateral half. Whenever there's a cubitus varus or gunstock deformity, think about supracondylar fractures of the humerus. Whenever there is a Gartland classification with displaced supracondylar humerus, that's going to be Gartland's type 3. Type 4, they will never ask you. Remember, nailing is secondary healing. Plating is primary healing, right? The image shown for fixation of intertrochanteric fracture is dynamic hip screw. This was done earlier, or for undisplaced fracture, nowadays it's almost being replaced by the proximal femoral nails. If there's a transition of the vertebra, break from anterior part of the vertebral body, posterior out of the vertebral body, sharing the spinous process, that's called as a chance fracture, also called a jackknife or the seat belt injury. Jefferson fracture is for atlas, hangman is for H2. Remember this point. The whiplash injury is hyperextension followed by flexion. Burst fracture, when the anterior and the posterior part of the vertebral body are gone, and when only anterior gone, that's called as a wedge fracture, because wedge fracture is something that you should remember. Going on to separation of skull into two parts is called as a motorcyclist or hinge fracture. And then chance fracture, as I told you, anterior to posterior, all the elements are broken. If there's a fracture of the base of the metatarsal, at the metaphysio-diaphyseal junction is called a Jones, and the tip is pseudo-Jones. And these fractures are treated by a splint or a cast for 6 to 8 weeks, right? When there's a slip of one vertebra over the other, it's called a spondylolisthesis, most commonly L5S1 level. When there is something that is behind the medial malleus palpalis, tibialis posterior, which goes and inserts on a bone called as a navicular, the scaphoid of the foot. When we look at the windswept deformity, think about hypophosphatemic rickets, it will have normal PTH. And when we talk about osteoporosis, what enzyme is raised? Tartrate resistant acid phosphatase. When you talk about a disc prolapse between L4, L5 vertebra, is going to compress the L5 nerve root. When they talk about the prominent tibial tuberosity, it's talking about the Osgood-Schindler disease as shown in this image. If they are going to ask about below knee amputation, this is the image. They can ask you any amputation as I've already discussed with you, right? So above knee amputation, below knee amputation, above elbow and below elbow are the four expected images that should usually be asked to you. All right. This is 20-degree flex knee trying to pull tibia anteriorly latchment test. When you have the neck of fibula, common peroneal nerve, dorsiflexion gone, called as the foot drop. When there is cock-up splint, it's a dynamic splint for radial nerve palsy, the most common asked splint in medical science. If they talk about a Shefford crook deformity, they want to talk about fibrous dysplasia to you. And when in this question, which exactly showed a patella part in the skyline view separated, there was written at the bottom, it's a bipartite patella. Bahut nahi sochna hota. You had to mark it. 50% cases, it's going to be bilateral. When they talk about cubitus valgus, they can ask you lateral condyle humerus non-union. When they talk about fractures of shaft of humerus, they had shown an image and asked you. When they talk about fracture femur with breathlessness, with rashes, they're talking about fat embolism. Mark it, go for it. Don't think in these cases. When they talk about lower end radius, a tumor which is going till the joint, it's giant cell tumor. This question has been asked. And another name for giant cell tumor is osteoclastoma. If they talk you about lateral 3.5 fingers numbness, you need to shake at the night, it's carpal tunnel syndrome, Durkan's test. That is what is the direct compression test. When they talk about a man with back pain and stiffness, reduced chest expansion, the moment you read red eye or heel pain, you're talking about ankylosing spondylitis. Spot on. When they talk about cubitus varus with widening around the joints, we are talking about vitamin D deficiency or rickets. When they talk about lytic lesion in the bones, right, at any age, think about enchondroma as a common cause. When they talk about intermittent breaking of long bones in a child or at birth, it's osteogenesis imperfecta, collagen 1 defect. This image was particularly shown to show you that there is a hip flexion deformity because of spine disorder. Why would a spine disorder cause a hip flexion deformity? Because there is a muscle that comes from the spine, right, called as iliopsoas, that has an origin from that area. When the psoas muscle is coming and there's a pus coming down, trickling into psoas from the spine, that's going to cause flexion deformity, right, which is a pseudo flexion deformity and seen in TB spine. And if this is what they want to say, they are trying to make a fist for the first two fingers stand out. This is called as the pointing index sign. And then you need to remember, if a child or anybody has a trauma of upper limb and you can't flex your elbow and you can't do a supination, it means that the musculoskeletal nerve is gone, which supplies the lateral aspect of the forearm, the sensory supply, right? Hip dislocation is up and in. It is posterior dislocation, flexion, adduction, introduction, and shortening. Reduce it, that's the treatment. And when there is osteoporosis, the drug of choice is bisphosphonates. Any age, can be given up to 5 years. Then there's a dose interval, can be repeated again. Teriparatide, low dose PTH, can be given up to 2 years. Denosumab, something that is going to inhibit the rank ligands. Subcutaneous, given every 6 months, can be given up to 10 years, 20 doses. If there is sclerotic margin of epiphysis with white line of Frankel, you're talking about vitamin C, that is ascorbic deficiency, scurvy, right? And this is what you need to remember about the key points of orthopedics till 2025. I've tried to give you so that you don't miss it out. Be committed, work hard, leave on to good God above. That's the only thing that will help you survive and help you do good in life. Dare to chase. Go with a positive mind frame. आप नहीं तो कौन? मैं खेलेगा is the rule of game. Show up. If you take it till the end, you will be the one to be crowned. If you don't, it's going to get over. Draw a plan. Before you sleep, whatever may happen, follow it. Don't give a 0 day at this time. तेरी किस्मत दा लिखा तेरे तो कोई खो नहीं सकता. तू श्रम करा चल बंदे. जो उसकी मेहर हुई तुझे वो मिल जाएगा जो तेरा हो भी नहीं सकता. If you deny the given, if you defy the given, the good God above will rewrite your destiny. Thank you very much.